It turns out that what many assume about psychiatric nursing, that it's mostly about administering medications and clinical procedures, is completely backwards.
Really? That's wild. I always thought the meds were the main thing.
Yeah, but actually, the real heart of psychiatric nursing lies in the therapeutic nurse-patient relationship, this artful, deeply interpersonal process that can profoundly influence patient outcomes beyond any medication.
Huh. So it's less about the pills and more about the connection?
Exactly. And why does this matter? Because understanding and mastering this relationship can mean the difference between a patient's recovery or prolonged suffering. It shapes how psychiatric nurses navigate complex emotional, ethical, and clinical challenges every day.
That's huge. So by the end of this episode, listeners will get a richer, more nuanced understanding of this relationship, its phases, boundaries, psychological dynamics, and the personal qualities that make it effective.
Right. It's really the foundation of psychiatric nursing, even though it's often overlooked.
So maybe we should start with a real-world example to ground this?
Absolutely. There's this story about Dan, a guy who was normally very well put together, a professional in a high-stress management job. But he suddenly deteriorated mentally due to a drug reaction combined with stress.
Oh, I remember that one. His friends took him to the hospital, and a psychiatric nurse met with him in the emergency department, right?
Yes. Dan was barely able to speak, hadn't bathed, and was almost incoherent. The nurse's approach was calm and paced, pausing often, speaking in a relaxed way, including Dan's wife in the interview, and making sure everyone took breaks.
That's such a contrast to the usual rushed clinical environment. It sounds like the nurse really prioritized dignity and respect.
Exactly. The nurse acknowledged that sometimes people who are normally well put together can have serious difficulties due to various factors. That simple respect helped establish trust and made the situation manageable.
So this is the art of psychiatric nursing, the therapeutic use of self, empathy, and respect that builds trust and facilitates recovery.
Yes, and it's a reminder that psychiatric nursing is both art and science. Sure, knowledge of anatomy, pharmacology, and physiology is essential, but the nurse-patient relationship is the foundation.
And that relationship is therapeutic, goal-directed, and based on trust, empathy, respect, and authenticity.
Right, but it's not just about the patient. Nurses must be self-aware, understanding their own needs and values, to avoid interfering with the patient's care.
That's a critical point. The relationship isn't social or intimate. It's professional and therapeutic, focused solely on the patient's needs.
Exactly, and that brings us to the concept of therapeutic use of self.
That's when the nurse consciously and genuinely uses their personality and communication skills to establish relatedness and structure interventions, right?
Yes. It's not a technique per se, but an attitude rooted in personal values and enhanced by microcommunication skills like warmth and empathy.
And there's scientific evidence supporting its efficacy as an intervention, which is reassuring.
Definitely. Now, it's important to clarify the difference between social and therapeutic relationships.
Social relationships are mutual, like friendships where both parties' needs are met. Therapeutic relationships are goal-directed, patient-focused, and involve a power imbalance.
Exactly. Boundaries protect the patient's vulnerability and the nurse's professional role.
Boundaries are established through treatment planning, space, comportment, like dress and language, and location of service.
Right. But boundaries can become blurred, often linked to transference and countertransference, which can be insidious and harmful.
Can you give examples of blurred boundaries?
Sure. Over-involvement, like buying gifts for patients, or keeping secrets, or avoidance, like not spending enough time with the patient.
That makes sense. And transference is when the patient unconsciously projects feelings from significant past relationships onto the nurse.
Yes, and it can be positive or negative. For example, a patient might see the nurse as cold like a parent.
And countertransference is the nurse projecting their own past feelings onto the patient, which can impair care.
Exactly. Both are intensified in therapeutic relationships due to authority dynamics.
So nurses need to self-reflect and seek supervision to manage these dynamics.
Yes. Common countertransference reactions include boredom, rescue attempts, over-involvement, over-identification, misuse of honesty, anger, and helplessness.
Managing these reactions is essential to maintain therapeutic effectiveness and patient safety.
Absolutely. Now, nurses' own values and beliefs influence their interactions.
So awareness and acceptance of one's own values and sensitivity to patients' differing values are critical.
Right. Avoiding judgmental attitudes is essential to maintain therapeutic rapport.
Supervision and mentorship help nurses develop this sensitivity.
That's a key support. Now let's talk about Pollard's model of the nurse-patient relationship.
Introduced in 1952, it remains foundational.
The relationship evolves through phases: pre-orientation, orientation, working, and termination.
Pre-orientation is when the nurse prepares by self-reflection and learning about the patient.
Orientation is the first meetings, establishing rapport, clarifying roles, setting contracts, discussing confidentiality, and termination.
Working is active problem-solving, exploring patient issues, managing resistance, promoting behavioral change.
And termination is closure, summarizing progress, planning for future coping, managing feelings about separation.
Even brief encounters can be therapeutic if genuine concern and respect are shown.
Exactly. And there are practical examples of handling patient behaviors during orientation, like suicide threats, personal questions, sexual advances, crying.
Those are tricky moments that require skillful responses.
Definitely. Now, research shows consistency, pacing, and listening are key to building trust and rapport.
Consistency means the same nurse assigned, regular meeting times and places, congruent communication.
Pacing means letting the patient set the speed of engagement, adjusting to moods.
And listening means truly attending to what is behind the words.
Negative factors include inconsistency, unavailability, and nurses' negative preconceptions or lack of self-awareness.
Mutual avoidance leads to superficial or failed relationships.
Exactly. Now, key nurse characteristics that promote patient growth include genuineness, empathy, and positive regard.
Genuineness is self-awareness and authentic communication that builds trust.
Empathy is understanding the patient's perspective without judgment or projection.
It's important to distinguish empathy from sympathy. Empathy imagines the patient's feelings. Sympathy feels them, which can impair objectivity.
Positive regard is respect and belief in the patient's worth and potential, communicated through attitudes and actions.
Attending behaviors, posture, eye contact, body language are foundational.
Suspending value judgments allows exploration of patient behaviors without bias.
Helping patients develop their own resources fosters independence and empowerment.
Now, shifting gears a bit, cultural competence is crucial, especially with indigenous patients.
Right. The research on the Nehiawak, or Plains Cree, perspective highlights that mental health disparities are linked to colonization and historical trauma.
Indigenous mental health is holistic, physical, emotional, mental, and spiritual well-being.
4 key themes for well-being are relationships, spiritual beliefs and cultural practices, worldview and personal agency.
For indigenous patients, honoring values like interconnectedness, reciprocity, language, and ceremony is essential.
This underscores the need for culturally sensitive therapeutic relationships.
Absolutely. Finally, clinical supervision and mentorship are vital for managing complex dynamics like transference, countertransference, and boundary issues.
They provide emotional support, education, and ethical guidance.
Regular reflection and supervision improve self-awareness and clinical competence.
So to wrap up, the therapeutic nurse-patient relationship is the cornerstone of psychiatric nursing, more impactful than any medication alone.
It requires a skillful balance of professional boundaries, self-awareness, empathy, and respect.
Understanding and managing psychological dynamics like transference and countertransference is essential.
Nurses, personal values, and cultural competence shape the quality of care.
Pollard's model offers a practical framework for developing these relationships through phases.
Ultimately, the art of psychiatric nursing lies in the nurse's ability to be genuinely present, empathetic, and respectful, fostering patient growth and healing.
That's a powerful reminder of what really matters in this field.
Definitely. It's about being human with patients in the most professional and caring way possible.